is and how the data call relates to it. And thank you, Audrey, for starting the recording. We're going to, again, be focused on changes from 2025 data call to the 2026 data call, primarily reporting timelines, those technical updates. Then we'll go into suggested consistency and trend checks, things that will make everyone's life smoother as we collaborate to get this really wealth of information onboarded and analyzed in good time. We will go over some office hour times that we can, again, sort of work one-on-one with you if needed to answer any questions, any things that come up along the way. And then again, we'll have that time for Q&A. Next slide, please. So first, what is the cost board and what is the cost growth benchmark? Next slide, please. So the cost board was established in 2020, so relatively new program, but we're certainly getting our sea legs now. And it was established by state law. It's been adjusted a few times since, but it's really charged with establishing, a healthcare cost growth benchmark, which is really a target for healthcare spending growth to stay below. And the cost board has established this benchmark rate and analyzes total healthcare expenditures in relation to that rate. It does so at a variety of different levels, at the state level, at the healthcare market level, and at the carrier and provider level as well. So those entities are compared to the benchmark each year. And alongside of this, we report to the legislature. We do so in essentially two ways: through an annual legislative report, but also through an annual public hearing. This will happen in roughly the November timeframe, and this is a chance for the board to have a public venue to review that comparison against the benchmark at all those different levels, and to identify essentially policy opportunities for how we can sort of adjust and to slow that spending growth curve. Again, more information can be found online at that data call webpage. Next slide, please. So what is the benchmark? The cost board in 2020 and subsequent to 2020 established the cost growth benchmark as essentially a combination of median wage growth and per capita gross state product, essentially state GDP. And you can see the benchmark values that sort of fall out of that methodology. It's a 70-30 mix of those two factors each year. So in 2020, that benchmark was 3.2%. In 2026, we're looking at a benchmark growth rate of 2.8%. Again, that growth rate that we're trying to stay below as relevant entities. And coming this year, the board will be updating these target growth rates for future years. Next slide, please. This sort of data collection, data analysis, and comparison against the benchmark process all exists as part of an annual cycle that the board undertakes with its partners, including you all, to measure essentially total healthcare expenditures within the state to get a really high-level picture of what's going on, then to analyze those to sort of clarify what's going on with healthcare spending in the state, to report again to the public and the legislature to identify opportunities for improvement, and then to either through working with our partners or through legislation to implement those opportunities for improvement to essentially meet the goal of making healthcare more affordable in the state of Washington. Thank you all for being part of that process. And with the next slide, I will hand it over to Marty to get a little bit more into the details of the 2026 data call. Go ahead, Marty.
Yeah, thanks so much, Harrison. Next slide, please. So I'll go over an overview of what we have coming for the 2026 data call. We'll be specifically collecting data from 2023 and 2024. And something that's new from previous data calls is that we'll be adding a breakdown of non-claims data into that which is spent in primary care versus that which is spent in non-primary care. And this whole process will be adding to existing historical data going back to 2017. And note that we've established the benchmark, but it was only the cost growth is only measured since 2022. So now we will have a comparison to the benchmark for 2022, 2023 historically, and we'll add a comparison for the growth that we see in 2024. And we'll be measuring it in statewide performance as well as carrier performance, and also large provider organizations. Okay. And in terms of the timeline that we'll be following, note that we launched the data call on February 10th last week, and we expect to have all that data submitted by April 10th. And between April and June, we'll be conducting data validation, and then after, over the course of the summer and into the fall, we'll be conducting a detailed analysis and generating reports that we'll be sending to both carriers and providers, detailing how they performed against the benchmark. And all that culminates in the public hearing that will be held on November 18th. Okay, and in terms of the materials, as Harrison mentioned, there's the technical manual that goes into great detail in terms of what we expect to be submitted, and that data is submitted in the template that's provided. We'll provide a link for that as well. And on top of that, we'll also be having a frequently asked questions document. Now, we have one, and what we've been doing is frequently updating based on feedback that we hear from carriers, just to clarify any questions that that might be lingering. And so going into greater detail on the materials, the submission template is an Excel spreadsheet. Each submitter will be expected to fill it out and submit for the data call by April 10th, as mentioned. And it consists of 6 tabs this time in terms of where we expect carriers to fill in data. There are questions on the cover page, and then there are tabs for total medical expenditure, standard deviation of that spending, the line of business spending, pharmacy rebates that you might have gathered in the years that we're covering. And then there is a new tab, the primary care non-claims tab, and I'll go into some detail on that a little bit later. And as I mentioned, the technical manual will go into great detail in terms of what we expect in each of the fields for the tabs that were delineated above. And next slide, please. Okay, and note that for this particular webinar, we're honing in on just the details that are different from the previous data call. So we go into greater detail in everything else in the previous webinar that we had in 2025. So you can refer back to that recording if you have any questions that might not be covered in this webinar. So yeah, we'll be focusing on the 2026 updates specifically for this. Next slide, please. Okay, and in terms of the updates to the materials, so as I mentioned, we're expecting a new category, a new tab that will actually break down the spending for primary care for non-claims. And we're doing this because in previous years, we've been able to get claims data on primary care, but the legislature has requested or set a target that we should be spending roughly 12% of healthcare spending on primary care. And so we've been missing the non-claims portion. And so this effort is honing in on how much non-claims spending we might be having, and just to get a fuller picture of primary care spending in Washington. Note that there are additional questions on the cover page as well. And we also deleted one of the codes from both the ICC and the line of business. Okay, next slide, please. Okay, and so you'll be asked, as I mentioned, to submit data on primary care non-claim spending. And how that's going to look is the new tab that I mentioned, where we're breaking it down into non-claims spending that happens on primary care that aligns with the Advisory Committee on Primary Care's definition that was approved by the board a couple years ago. and also non-primary care, non-claim spending. Okay. And so that tab that I talked about, tab 6, the primary care non-claims. Now, there are stratification variables that will be very familiar to you, columns 1 through 4, and you'll be able to find those on the reference tab on the Excel spreadsheet. And then there, from columns 5 to 16, there are the non-claims subcategories, and I'll go into those in greater detail. Next slide, please. So what you'll see is a pair of non-claims subcategories on that new primary care non-claims tab. Spending that happens in primary care versus spending that happens in non-primary care. And they're basically paired between, they're basically paired with one of the TME columns. So note that you'll be submitting non-claims that happens for capitation and bundled payments in TME 16, and you'll break that down in the 5th and 6th columns on the new tab. And you should find that column 5 plus column 6 will equal that TME 16. Likewise, performance incentives, that will be broken down in the non-claims primary care tab, and so on. And so for the additional slides, I will hand it over to Sheriel.
Thank you, Marty. Yes, so in the next few slides, we are going to talk or take a closer look at the definitions of the various subcategories of primary care non-claim spending. In general, for non-claim spending to be considered primary care, those non-claims payments should be done for to primary care providers and or for services or investments that are primary care related. So the first primary care non-claim subcategory is capitation or bundled payments on primary care. This is labeled as variable PCNC05 in your data submission template. And this field consists of non-claims-based payments that are made to primary care providers to cover healthcare services. So this includes capitation, global budget, case rate, and episode-based payments. It's important to note that for global capitation payments or value-based payments that are made to healthcare providers that are prepaid, fixed, per member per month payments to cover for almost all or all healthcare services for a defined population, that payers have to estimate the portion of primary care to this global capitation payment. And so payers could do this in a variety of ways. You can do this by using historical portion of spending that is attributed to primary care. You can also use the share of service utilization to overall utilization, or can use total relative values for primary care as a proportion of total RVUs for services under capitation. And while we do not require submitters to submit the methodology used, if we encounter any validation issues along the road, we may reach out to ask for the details on how you have calculated this one. Another thing that is important to note is that if payers conduct leakage adjustments on capitated or subcapitated primary care expenditures, then the amount reported in this field should be net of leakage adjustments. And we refer to leakage as those services that are received outside a provider that the member is attributed to. So I will try to provide example to hopefully provide more clarity on how to treat leakage adjustment. Next slide, please. All right, so suppose we have a carrier, and we'll call we'll call this carrier A, and the carrier has a capitation arrangement with the provider group of PCP or primary care provider, Dr. Karen. And we have a patient or a member, we call him John Doe, and he is attributed to Dr. Karen. The capitation payment to Dr. Karen is set at $100. But then at some point in time, our member John Doe received services outside Dr. Karen. He received it from Dr. Fred, and because of that, Carrier A paid $40 to the provider group of Dr. Fred. So how should data submitters treat this spending? And the answer is it depends on how the leakage is adjusted. So in scenario A, where the $40 leakage is deducted from the capitated payments to Dr. Karen, the amount reported for PCNCO5 for the provider group of Dr. Karen should be $60. But in scenario B, wherein the $40 leakage is not deducted from the capitated payments to Dr. Karen, the amount reported for PCNCO5 for the provider group of Dr. Karen should still be 100. And in these both scenarios, there is no double counting of the leakage. And then in both scenarios as well, it's important to note that the $40 would also be reported for the provider group of Dr. Fred and would be categorized based on how the payment was done or the services was done, and also based on the definitions in the technical manual. Are there any questions before we move on this one?
Not seeing any. Again, feel free to raise your hand if you have any questions.
Or type your question in the chat as well. All right, having none, moving on to the next slide. Okay, the other,
Sheriel, I do see a hand now from Marissa, and I will go ahead and unmute you. 1 second, please.
Hi, thanks. Just one quick note, the chat is turned off, so we can't add questions in the chat. So we will have to raise our hands, no problem. I know it's an adjustment, that's okay. And I just wanted to clarify here with the new report due, is it July 31st? That is for regular primary claims. And this is, we're just doing non-claims primary care as part of the cost growth submission. Is that?
We already collect
the delineation between the two?
Oh, are you talking about the OIC data collection that is due in July, I believe?
The new Washington primary care report that is due July 31st this year for the first time.
Oh, we will be talking about the comparison of the two in a bit, but
okay, perfect.
Yeah.
Didn't mean to jump ahead. While we were on primary care, I wanted to make sure we touched on that.
Oh, that's great. Thank you, Marisa. Yeah, we'll do a comparison of like the difference of the two data calls. All right, moving on to the next slide. All right. So the second subcategory for primary care non-claims spending is PCNCO7, or performance incentives payments related to primary care. And these are basically net financial incentives, bonuses minus penalties made to primary care providers or practices in a value-based payment arrangement or APM, alternative payment model. And these are payments or incentives because like providers have met reporting or certain quality thresholds, and so they're given incentives for meeting these thresholds. So for these subcategories, one thing to note is that the incentives are the ones that we're looking for, and the actual payment for the service or the capitated rate should be reported under the capitation or bundled payments or PCNCO5. Moreover, the sign could be negative or positive depending if bonuses exceed penalties. That should be positive. But if penalties exceed bonuses, then that should be negative. Next slide, please. All right. The third subcategory is the population health and practice infrastructure payments for primary care.